Good afternoon. I'm going to talk about stroke center certification. I'm going to focus primarily on comprehensive and thrombectomy capable, but many of the principles apply throughout. First, I just wanted to talk about the agencies that I'm aware of that currently certify stroke centers in the United States. And we'll go by history, really, in terms of order here. First, there's the Healthcare Facilities Accreditation Program, HFAP. This is the oldest in the U.S., created in 1945, originally for osteopathic hospitals, but more recently for allopathic and osteopathic hospitals. And it's all hospitals that require compliance with what are called the Medicare Conditions of Participation and Coverage. In order to treat and bill CMS patients, you have to have accreditation by one of these organizations. The second and largest in terms of the United States is Joint Commission, formerly known as JCAHO, Joint Commission on the Accreditation of Healthcare Organizations, but now just TJC, was founded in 1951 to improve safe, high-quality care. Then you have the Center for Improvement in Healthcare Quality, CIHQ, which was founded in 1999, which accredits hospitals, LTACs, SNFs, and similar organizations. And finally, Det Norske Veritas Germanische Lloyd, DNVGL, or just DNV. This was actually founded in 1864, entertainingly enough, to inspect merchant vessels, but they have been in U.S. healthcare since 2008. They very specifically apply ISO 9001 quality management systems. So for those of you with the MBAs, you'll enjoy this organization. They do not insist that you know the ISO system, but it is based on those principles. Now, my disclaimers. So this is not about financial, this is about what my experience is. So I have been a comprehensive stroke center director and a primary stroke center director at both Joint Commission and DNV hospitals, but I have not done so for HFAP or CIHQ. I was on the technical advisory panel for the Joint Commission for CSC requirement development, but I have never been a surveyor myself. And for this talk, I've relied on primary source documents from most of the organizations except for HFAP. And in that case, I had discussions with the surveyor and certification advisors. And I've spoken to a number of certification advisors in the other organizations as well. But in summary, I cannot speak for the organizations. I can only speak to my experience. So the certification levels, essentially the same for all the organizations. They have slightly different names, but there's acute stroke ready, primary stroke center, thrombectomy capable stroke center, known in the DNV as primary plus, and then comprehensive stroke center for all four of the organizations. I do want to point out that if you're not currently a comprehensive and you're thinking of going for it, it's not simply that you've added on some new procedures. Oh, we can clip aneurysms or coil aneurysms and we can do thrombectomies. There is an expectation by all of these organizations that you will now be a leader in your region. So you are expected to provide education in a way that you did not before for other physicians and hospitals, and to lead by example at the very least. I will also say that each of these organizations will certify a stroke center irrespective of whether or not they accredit that hospital. So you could be a Joint Commission hospital and have a DNV stroke center certification, and that's true for any combination. The certification frequency is relevant in terms of you're making the decision about what you're willing to live with. Each survey is, as you know, rather burdensome and can be very intense. So you have to think about the trade-off of, do I want to do them less frequently so that I'm not feeling that intense as often, or do I want them more frequently so that I'm always prepared? The Joint Commission certifies every 2 years with a 2-day, 2-person visit. If you've done primary, you know that the 1-day, 1-person is 6 hours of intensity, and then that's about it. For the 2-day, it's 14 hours of intensity, and they're reviewing far more information than you're used to them reviewing. So that two-day, two-person visit is every 2 years, and there's a mid-cycle call at 12 months to review your progress, so 2 years apart. The DNV gives you a certification that lasts 3 years, but they will survey you every year with a two-person, two-day site visit. I will say, initially I found that very intimidating, but once I got used to it, it's actually nice. You're prepared pretty much continuously, and you don't feel like you're playing catch-up. The HFAP certifies every 3 years, again with a two-day, two-person site visit every 3 years, and has a mid-cycle call, or, in the case of a CSC, a one-day, one-person visit at 18 months. Fairly far between the really intense visits. And finally, the CIHQ certifies every 3 years with a one-day, one-person visit. I leave you to draw your own conclusions. Medical director requirements, these tend not to be the biggest deal in terms of making a decision about which organization to go with. The Joint Commission says it must be a physician with, quote, extensive experience and expertise in neurology and cerebrovascular disease. And they say that examples include a stroke or vascular neurologist, a critical care neurologist, or a vascular neurosurgeon. But I do know that they are perfectly content, well, not perfectly content, but they are content and will approve a CSC with a non-vascular neurologist at the helm, assuming he or she keeps up with the 8 hours of stroke CME annually and is knowledgeable at the time of the site visit. The DNV, on the other hand, is a bit more prescriptive. In addition to the 8 hours of CME, you must have two of the following: a fellowship, boards in vascular neurology, treatment of more than 50 stroke patients a year, and or 5 to 10 publications in stroke. You can see that most of those combinations are going to include either a fellowship or board certification, but it would be possible to do it just by having published a lot in stroke, even if you had never done a fellowship. HFAP requires a physician with board certification in neurology, neurosurgery, or neuroradiology, requires a bit more CME, 12 hours annually, and at least one of the following: a fellowship, 5 years experience, attending a conference like this one, publishing papers, or, quote, other criteria as determined by the organization. So it would appear that they are flexible. The CIHQ simply requires a physician with board certification in neurology, neurocritical care, neurosurgery, or neuroradiology, and 8 hours of stroke CME annually. They do point out that this person must not be a stroke medical director at another hospital, and they're the only organization to make that requirement. But I will point out that this could be a person without neurotraining other than being a neurocritical care specialist. And that is not defined in their documentation, by the way. Next is the neurocritical care unit. This is frequently a stumbling block for hospitals looking to make that jump. I will say that all but the CIHQ require designated neurocritical care beds. Now, for most of us, we think that that means you have to have a unit that is committed entirely to neurocritical care and nothing else, but that is not the case for any of the organizations. It may be a unit within a unit, so you could designate certain beds within your MICU or SICU as you saw fit. But those beds do have to be protected in some way by policy, and you must have an overflow protocol that must be available. In essence, you have to be able to say, we never turn away a stroke patient. We always will make a critical care bed for this patient. The neurocritical care specialist is another area of concern. And they all phrase it a bit differently, and as you'll see, it's all a bit vague. So the Joint Commission says that neurocritical care providers must have neurocritical care privileges. That means it's up to you to define what a neurocritical care specialist is, create a certification process for it, not a credentialing process for it, and then live up to that. In way of guidance, they have this quote here saying that training in cerebrovascular and neurocritical care can be demonstrated through completion of an educational program, and one of those examples is ENLS. So for those of you who are board certified neurocritical care specialists, I apologize because ENLS obviously is something that could be done in about 14 hours. Not that it's trivial by any means, it's very important, but it's a far cry from a fellowship. So fellowships are not required, and board certification is not required. The neurocritical care person must be in-house 24/7 or have coverage by residents, fellows, or APPs. So there's flexibility there as well. The DNV is a bit more prescriptive, but again has flexibility. The providers should be board eligible neurologists, neurosurgeons, anesthesiologists, or internists who have completed either a critical care fellowship or a neurocritical care fellowship. But as you can see, this means it doesn't have to be neurocritical care. So your standard variety pulmonologist who becomes a critical care specialist could be your neurocritical care doc, assuming he or she takes care of at least 20 acute stroke patients a year and completes the 8 hours of CME a year. HFAP simply says must have training and expertise in neurocritical care, could be a neurosurgeon or a physician with expertise and training in, and then it talks about the essence of neurocritical care that you might see in ENLS. Again, must be in-house 24/7 or have coverage by residents or fellows or APPs. I will point out, going back a slide, with the DNV, that is not specified. I believe it is their expectation that you will have adequate coverage, but it does not prescribe who must be in-house 24/7. The CIHQ simply says expertise in neurocritical care and cerebrovascular disease and does not detail it beyond that. Must be in-house or have coverage as for the other two organizations. Next, and perhaps the most challenging, is the interventionalist requirements. So neurointerventional radiology, if you'll accept that term, is defined in a variety of ways. The Joint Commission says they have to be CAST certified or all of the following. So have neuroendovascular training in a CAST accredited program, not necessarily be certified as an individual, but as a program, or similarly rigorous training program. I leave it to you to define that, and I guess they leave it to you as well. Not that they would ignore the program, but they would allow you to define what rigorous meant. If it's a neurologist, they must have a stroke or neurocritical care fellowship as the base on which you then build to neurointerventional. And if a radiologist, they must have neuroradiology training prior to their interventional training. The DNV, on the other hand, does not specify what the training of your neurointerventionalist need be, raising the question of whether this could be an interventional radiologist who is not a neurointerventionalist. And I guess that's a good segue into tomorrow's debate about who should be allowed to do thrombectomies. I will say, though, I think it rather unlikely that a non-neuro interventionalist is going to coil aneurysms. So I think ultimately you're going to end up with an appropriate number of people who can take care of your aneurysms, but who does the thrombectomies is another story. The HFAP also does not specify, and the CIHQ says neuroendovascular training in a CAST accredited program and leaves it at that, which would make it the most stringent of the four in terms of its requirements. And it also says that if this is a neurologist, must have stroke or neurocritical care fellowship, and if a radiologist, must have neuroradiology training. So keep these in mind. These are usually the most challenging. I will also say that the neurointerventional call requirements can be very tricky. The Joint Commission, in my experience in a number of surveys at a number of organizations, has been very focused on backup. So they are always focused on, can you take care of two cases simultaneously, which you might say means, okay, I have to have backup. I have to have two neurointerventionalists. But then they will follow up with, well, what do you do when one of those people is on vacation? and show me the call schedule that tells me that you have that depth 365 days a year. So what that really means is you have to have a minimum of 3 neurointerventionalists in order to pass this certification. The DNV does not have a specified backup requirement, nor does it specify how many hospitals you might be responsible for on any given night of call. The HFAP does not have a specified backup requirement, but they say that you cannot be on call for more than one hospital. And the CIHQ does not have any specified backup requirement, but says you must address how you would handle multiple complex patients at a time. So certainly you have to have a minimum of 2. Volume requirements are a big issue for programs, particularly in rural areas. I was in Oregon for a number of years, so Central Oregon, this was a big challenge. They wanted the ability to have a comprehensive stroke center in an area that was otherwise, you could only get to, transfer patients via fixed wing, but they could not be confident of having high volumes. So here are the volumes. All of them require subarachnoid hemorrhage volumes at your hospital of 20 a year at a minimum. And I will say that you will not even get to the point of getting a survey if you do not meet these volume requirements. They will ask for them in advance and reject you if you don't document them. For coiling and clipping, the Joint Commission requires 15 per year, and the others require 10 per year. None of them specify any longer how many you do of which procedure, clipping or coiling. And while I certainly hear them express concern that if you're doing 95 coilings a year and 3 clippings, they must say, well, how do you ensure competence of the people who are doing the clippings? But it has not led to a denial of certification that I've heard of. TPA, there are requirements that you have 25 TPA cases per year for all of these organizations except for HFAP, but they do specify that any of those can be met with patients that receive TPA at one of your spoke hospitals and are transferred in. Thrombectomy volumes are challenging and highly variable. So the Joint Commission says you have to have 15 a year. But in addition to that 15 a year for your hospital, you must have 15 a year for each of the interventionalists who are on your call schedule. So you can't have one interventionalist who does almost all of them and a backup person who does 1 or 2 a year. Now, they could do their 15 at other hospitals. It's about personal competence. But the bare minimum would be you've got 3 interventionalists, each of whom is doing 15 cases, and at your hospital, 15 of them have to have occurred there. That's a challenging combination. And if you happen to have 4 people on the list, all 4 of them have to have 15. In the case of in the case of DNV, it is 15 for the hospital and at least 25 over a 2-year period in the initial application. So they'll let you slide a little bit with the initial application, but for the recertification, it's 15 a year. And by the way, I think for all of them, they'll let you average over 2 years. In the case of HFAP, 15 for the hospital will accept a lower number in the initial application, although they do not specify what that number is. And the requirement for each of the interventionalists is 15 over 2 years, so 7.5 on average, and the latter may be at other sites. And then finally, more for the interest of the stroke coordinators at the sites, the measures required vary pretty substantially. So the Joint Commission and HFAP all require the STK measures that the primaries are required to have, 1 through 6, 8, and 10. And then in addition, for the CSTKs, 1, 3 through 6, and 8 through 12. In the case of thrombectomy capable, we can exclude 3, 4, and 6, which are about ICH and SAH scores, etc. For the DNV, it's the largest number of measures required. It's all of the STK and all of the CSTK. And then CIHQ is mysteriously silent about this. They just say at least 2 relevant, valid, and reliable clinical performance measures. And I have no experience of how few there could actually be, but it sounds like it's only 2. And then all of them require that you track your TPA rates for the 3 and 4.5-hour windows, as well as your door to CT times. And that is it here on the last page. If you're interested, these are all the references. You can find DNV, Joint Commission, and CIHQ on the internet. The HFAP is not available unless you pay for it. So I got this information from one of their certification advisors. Thank you.